Welcome, everyone. Today we're diving into a crucial topic in cardiovascular health: abdominal aortic aneurysms, AAA, and aortic dissections. These are two serious conditions that demand immediate attention and treatment. Throughout this chapter, we'll explore their key characteristics, screening methods, and management strategies. By understanding the nuances of these life-threatening conditions, we can better equip ourselves to identify and address them effectively. So let's explore this essential overview and enhance our knowledge in cardiovascular care. Let's talk about abdominal aortic aneurysm screening. Screening for abdominal aortic aneurysm is recommended for men aged 65 and older with a history of smoking. It's a critical step in early detection and prevention. Ultrasound serves as the primary diagnostic tool for detecting abdominal aortic aneurysm. It helps identify the hallmark sign of an abdominal aortic aneurysm, a pulsatile abdominal mass. It's important to note that most abdominal aortic aneurysm patients are asymptomatic. However, some may experience subtle signs like abdominal pressure or back pain, but here's the crucial part. Severe, sudden back pain could signal abdominal aortic aneurysm rupture, a life-threatening emergency that requires immediate attention. In addition to male sex and smoking, other risk factors for abdominal aortic aneurysm include hypertension, family history, and certain connective tissue disorders like Marfan's or Ehlers-Danlos syndromes. Understanding these risk factors and the importance of screening can help us identify abdominal aortic aneurysm early and prevent potentially fatal complications. Now, let's discuss the treatment options for abdominal aortic aneurysms. Beta blockers play a crucial role in managing hypertension in patients with intact abdominal aortic aneurysms. Additionally, they are used to slow the growth of the aneurysm, mitigating the risk of rupture. When it comes to larger abdominal aortic aneurysms, typically 5 cm or larger in diameter, or any abdominal aortic aneurysms in patients with Marfan's or Ehlers-Danlos syndromes, surgical repair becomes the recommended course of action. This intervention aims to prevent rupture and its potentially life-threatening consequences. For smaller abdominal aortic aneurysms that don't meet the criteria for surgical repair, close monitoring is essential. Regular ultrasound imaging is employed to track any changes in size, allowing for timely intervention if the aneurysm shows signs of growth or instability. By tailoring treatment approaches to the size and characteristics of the abdominal aortic aneurysms, we can effectively manage the condition and reduce the risk of complications. Now let's shift our focus to aortic dissection, another critical cardiovascular condition. Aortic dissection typically presents with severe, sudden onset chest or back pain. Unlike ruptured abdominal aortic aneurysms, which may lead to hypotension, aortic dissection is often associated with hypertension. Diagnosis hinges on a combination of clinical evaluation and imaging. During a physical exam, asymmetric blood pressures between the right and left arms may raise suspicion. Additionally, imaging studies such as a chest X-ray may reveal a widened mediastinum, further supporting the diagnosis. Aortic dissections are classified into two main types: Type A, which involves the ascending aorta, and Type B, limited to the descending aorta. Type A dissections require urgent surgical repair due to the high risk of complications, including aortic rupture and organ malperfusion. On the other hand, Type B dissections are often managed medically, with a focus on blood pressure control and pain management. By understanding the presentation, diagnosis, and classification of aortic dissections, healthcare providers can initiate timely interventions and improve patient outcomes. Let's take a closer look at the treatment strategies for aortic dissection. For acute type A aortic dissections, immediate surgical intervention is paramount. This surgical procedure aims to repair the tear in the ascending aorta, mitigating the risk of life-threatening complications such as aortic rupture or organ malperfusion. On the other hand, type B dissections, which are limited to the descending aorta, are typically managed differently. Here, the focus is on controlling blood pressure to prevent further dissection and complications. Intravenous antihypertensive medications play a key role in achieving this goal. Patients with type B dissections require close monitoring due to the potential for disease progression or the development of complications. In some cases, surgical intervention may be necessary if the dissection advances or if complications arise. By tailoring treatment approaches to the specific type and severity of the aortic dissection, healthcare providers can optimize patient outcomes and reduce the risk of adverse events. Let's discuss the relationship between Marfan's syndrome and aortic disease. Individuals with Marfan's syndrome face a significantly increased risk of developing aortic aneurysms and dissections. This heightened risk stems from the underlying connective tissue disorder characteristic of Marfan's syndrome. Early intervention is paramount for patients with Marfan's syndrome. They require close monitoring of their aortic diameter to detect any signs of dilation promptly. Early surgical intervention is often necessary to prevent catastrophic complications such as aortic rupture or dissection. In addition to monitoring, genetic testing and counseling play crucial roles in managing Marfan's syndrome. These interventions help individuals and their families assess the risk of passing on the condition to future generations. By understanding their genetic predisposition, individuals with Marfan's syndrome can make informed decisions about their health and family planning. Now, let's turn our attention to Ehlers-Danlos syndrome, EDS, and its association with aortic disease. Ehlers-Danlos syndrome is yet another genetic connective tissue disorder that predisposes individuals to aortic aneurysms and dissections akin to Marfan's syndrome. What sets EDS apart is its increased risk of spontaneous arterial rupture, which can result in life-threatening bleeding. This heightened risk underscores the importance of close monitoring and a multidisciplinary approach to managing patients with Ehlers-Danlos syndrome. Given the potential for aortic and vascular complications in individuals with EDS, a comprehensive strategy involving regular monitoring and collaboration among healthcare professionals is essential. By addressing the unique challenges posed by EDS, we can better mitigate the risk of adverse outcomes and improve patient outcomes. Let's recap the essential points we've covered. For abdominal aortic aneurysms, screening is recommended for men aged 65 and older with a history of smoking. Most patients are asymptomatic, but severe back pain may indicate rupture. Surgical repair is indicated for abdominal aortic aneurysms, 5 cm or larger, or in patients with connective tissue disorders. Regarding aortic dissections, they present with sudden, severe chest or back pain and hypertension. They are classified as type A, involving the ascending aorta, or type B, limited to the descending aorta. Type A dissections require urgent surgical repair, while type B dissections are often managed medically. And for connective tissue disorders, Marfan's and Ehlers-Danlos syndromes increase the risk of aortic aneurysms and dissections. Close monitoring and early surgical intervention are crucial to prevent complications in these patients. By understanding these key points, healthcare providers can better recognize, diagnose, and manage abdominal aortic aneurysms, aortic dissections, and associated connective tissue disorders, ultimately improving patient outcomes.